Burkitt's lymphoma. Burkitt's lymphoma is a rare and aggressive type of non-Hodgkin lymphoma that arises from B lymphocytes. It is characterized by a reciprocal translocation involving the CMYC proto-oncogene on chromosome 8 and the immunoglobulin heavy chain locus on chromosome 14, leading to uncontrolled cell proliferation. Peak incidence. There are 3 recognized forms of Burkitt's lymphoma. Endemic form. This is associated with Epstein-Barr virus, EBV, common in Africa, especially children. Sporadic form. This is the most common in Western countries. It typically affects children and young adults 10 to 30 years old. Immunodeficiency-related form. This is seen in individuals with HIV or other causes of immunosuppression, more commonly affects adults. Pathophysiology. Driven by a T814 translocation which fuses the CMYC gene with the immunoglobulin heavy chain locus, resulting in overexpression of MYC. This promotes uncontrolled cell division and tumor growth. EBV infection is strongly linked to the endemic form, promoting B-cell proliferation. Immunodeficiency allows unchecked viral-driven lymphoproliferation. Symptoms: lymphadenopathy, cervical, axillary, inguinal. B symptoms: fever, drenching night sweats, and weight loss. Endemic form: jaw or maxillary masses. Sporadic form: abdominal mass, abdominal/back pain, and diarrhea. Signs: rapidly growing, painless mass in the abdomen, jaw, or neck. Generalized lymphadenopathy. Exophthalmos if orbital involvement in the endemic form. Rarely CNS involvement, headaches, visual changes, and seizures. Diagnosis. Clinical assessment: lymphadenopathy, hepatosplenomegaly, jaw or abdominal tumors. Imaging: CT or MRI to assess tumor extent. Ultrasound for abdominal masses and organomegaly. Biopsy: lymph node or bone marrow. The classic starry sky appearance on histology, macrophages among sheets of tumor cells. Genetics: MYC translocation T814. Immunophenotyping: CD20, CD10, and BCL6 typically positive. EBV serology identifies endemic association. Lumbar puncture if CNS involvement is suspected. Management: chemotherapy. Intensive regimens such as CODOX-M, IVAC, or hyper-CVAD. Intrathecal chemotherapy. This is used in cases with CNS involvement or prophylaxis. Rituximab, a monoclonal antibody against CD20. It improves survival when added to chemotherapy. Tumor lysis syndrome prophylaxis. Hydration, allopurinol, or rasburicase. Antiretroviral therapy for HIV-positive patients. Autologous stem cell transplantation. This is considered for relapsed or refractory cases. Complications: tumor lysis syndrome, hyperkalemia, hyperphosphatemia, hypocalcemia, hyperuricemia. Risk of renal failure and arrhythmias. CNS involvement requiring intrathecal chemotherapy. Infections due to chemotherapy-induced immunosuppression. Relapse of disease. Prognosis. Prognosis depends on stage, tumor burden, age, and comorbidities. Children and young adults often respond well to chemotherapy. Endemic form, good prognosis with appropriate chemotherapy. Sporadic form, highly responsive to intensive regimens. Immunodeficiency related form, poorer prognosis due to immune dysfunction. Adverse factors, advanced stage, CNS or bone marrow involvement, high LDH, HIV co-infection. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today